Person here with Aortic Hope Live for our next live Q&A. I told you this month was going to be busy and I was not lying. It is Aortic Disease Awareness Month and we're really excited for our next guest, another first timer that we have on with us. But before we get into that, do me a favor, click that like button and click subscribe and that bell now because we all know if we've had open heart surgery, you're not going to remember what I'm saying right now by the end of tonight. So click the subscribe button now and then you'll be notified the next time we go live, which is going to be, could be this weekend with a live Survivor series, could be Monday for our weekend review, who knows, but you know you're going to want to stay tuned and hear it. So without any further ado, I'm excited to present to you Dr. Mascaro. First time having you on with us. Thank you so much for joining.
Oh, it is a pleasure, Karin. Thank you very much for having me here.
So please tell everybody a little bit about you and where you're located, because that's just going to blow everybody's mind.
Oh, yeah, that's it. This is my new location.
Okay.
As said, I'm Dr. Mascaro, Jorge Mascaro. I trained in the United Kingdom. I practiced in the United Kingdom for 20 years, and now I am based in Milwaukee, Wisconsin. Um,
That's why I said it's going to blow everybody's mind because they're going to be like, I'm sorry, where are you based? Where
yeah,
is that again on the map? Right. Because it seems so far remote for so many people.
It it is very remote for me. I never
Yeah.
thought I was going to be here in the United States, working here and practicing medicine here. I thought my final destination was going to be the United Kingdom. By and large, I was born in South America, in Chile. So
Mm-hmm.
my traveling around the world has been quite extensive, probably.
Okay.
So yeah, in Milwaukee, at Medical College of Wisconsin, and Frederick Hospital, where I was hired here to come and develop lung transplantation and direct the program of lung transplantation.
Interesting.
However, in the United Kingdom, being the director of the transplant program, I was also the head of aortic surgery.
Okay.
And yeah, bringing all that experience here to Milwaukee and Wisconsin and trying to serve patients, trying to do the best for them and offer not just transplantation, but also aortic surgery to them.
That's amazing. Because the first time we spoke, I think we found out about each other from Gareth Owens over at ADA UKI in the UK. And when we spoke, I know you had said to me that you serve a patient population from 4 different states can actually come to your location for, surgery and treatment, correct?
That's correct. Yeah,
Yeah.
yeah, that's absolutely correct. I think uh, I am still adapting, I have to say, to the
Mm-hmm.
way of living and not just to the way of living, but to the way of working here in the United
Right.
States.
Right.
So it is an experience. It is a new experience, and from a socialized system that is in the United Kingdom to come to a different system here takes time.
Mm-hmm.
You need to get used at the way how things are done. But yeah, trying to wave the flag of of aortic surgery and everything that comes along with it, all the treatment of aortic diseases, connective tissue disorders,
Right.
and all of that, and trying to develop everything in Milwaukee.
Right, exactly. And we were just talking before you jumped on. I'm really curious, living on the East Coast in Maryland, so, pretty centrally located between DC and New York, pretty big hubbub here. And then you have the West Coast. Again, they've got some large, well-known hospital systems, fairly metropolitan, but very different feel from the East Coast. Then there's this whole middle of the country. And what I have been finding that's pretty interesting is you hear of stories that access is just not the same. I mean, I can walk outside and I'm within 45 minutes of major hospital systems all around me. I could go to any of them and I'm comfortable. And I can't even imagine a life where, kind of like in Canada, you've got one shot to get to the right medical center and to make sure you're diagnosed and someone is thinking about your aorta. See what I did that? I pulled that in. Or you could be in trouble if you're misdiagnosed. So what has that been like for you?
That's quite true. I guess. Yes, it is very different. The United Kingdom is probably half the size of Wisconsin, so
Yeah. Okay.
the whole of England fits
Right.
in a corner in Wisconsin. So distances are completely different, and you
Yeah.
need to get used. You need to get used to that. Um, as an example, actually, people do have access to the treatment of diseases. In the past 2 weeks, I've operated on 2 aortic dissections that they didn't generate it in Milwaukee, but further north in Milwaukee. And I have to say that I was quite impressed on how quick they were transferring from the places where they were diagnosed, to the point that in less than 2 hours they were in the operating room.
Wow.
And I thought that was quite impressive,
That is
because
very impressive. Yeah.
even in the United Kingdom, where the system is completely centralized, you could say, and everything doesn't depend on economy or financial. Well, there is financial problems everywhere, I have to say, but where things are not dependent necessarily on
Insurance.
availability and insurances and all
Right.
of that. Actually, we had longer waiting times in the UK than the 2 patients that I saw that I have
Wow.
seen here. So
Huh.
I was really quite impressed on how well the system worked.
That's great. That's
And
good
that's
to know.
at least here in Wisconsin. I don't
Yeah.
know how it is on the East Coast. I don't know how it is on the West Coast. Populations are very different. It's much more densely population in the East and West Coast rather than in the Midwest. So that may be a different over there. But
Yeah.
I guess so far things look very good here in Milwaukee, and developing everything that we can.
Well, I'm glad. I'm glad you're settled in, because I know it's taken a little bit of time to let you settle in to what you're doing,
Yes.
find your groove. So, as you know, well, way back when, Aortic Dissection Awareness Day was always September 19th, and then people branched it out to Aortic Dissection Awareness Week. A few years ago, we kind of changed things to Aortic Disease Awareness Month. We moved it to aortic disease because, we know that dissections are rare, but aortic disease in and of itself is much more common than anybody realizes. So why not try to educate and capture those individuals that might be at risk before they even get to the point of dissection? Let's figure out via family medical history, determine who needs to be diagnosed, who needs to be monitored, right? So you can't teach this community everything from what is an aorta, aneurysms, bicuspid valve regurgitation, stenosis treatment, and dissections, and genetics, and medicine, and emotional health, all in one day or 1 week. So it takes us a whole month. So if we were just to do a broad spectrum review again with everybody who may have missed our prior events, let's just talk about the aorta, which is now its own organ, which I'm not sure is something we should be applauding, or it doesn't really matter. It's up to you if you want to go into that a little bit, because we do know it's the largest vessel.
Yes, I think it's very interesting what you're just saying. The aorta is now an organ,
right?
As if it wasn't before.
Yeah.
and I think all of that comes with the awareness and the recognition that the medical community has given actually to the aorta. In general, you talk to the general public and you say, do you know what the aorta is? Yes, it's a tube that distributes blood through everywhere to the body. And in actual fact, as you're saying, the aorta is quite an interesting tube from that point of view. It's a tube that has different behaviors in depending if it is the first segment of the aorta, if it is the aortic arch, if it is the descending thoracic aorta or if it is the abdominal aorta. All those different segments of the aorta are actually affected by different types of diseases, and they behave differently as well.
Mm-hmm.
And that makes that recently at one of the last development guidelines that was published led the medical community to recognize the aorta as an organ, actually, not just this tube that is a motorway that transports blood from one end to another one, but a more complex structure that needs to be addressed in its different segments by the different diseases that can affect it.
Which is interesting. So it does, depending on zones.
It's actually fascinating. Yeah.
Yeah.
It's actually
it is fascinating because you just look at it in one respect and it's the largest vessel. It sends all the blood to all the parts of your body, but you could have potentially a different way of diagnosing the ascending versus diagnosing the abdominal, or at least different ways of typically first line of monitoring. Yeah. Then there might be different ways of treatment based upon sizes. That differs in different areas on what size before you intervene, what type of intervention. So it is very fascinating.
It is. And for example, when we see from that point of view, probably one of the most common problems of the aorta is an aneurysm of the abdominal aorta.
Yep. Yeah. We were just talking about that earlier today. So I'd love to hear you talk more about that.
Well, the aneurysm of the abdominal aorta is a very particular entity, which doesn't mean that you're going to develop aneurysms anywhere else in the aorta, for example.
Yeah.
So patients many times they think or they may think actually that by having an aneurysm in the abdominal aorta, they will develop aneurysms anywhere else. But no, that's not the case. In a different way, aneurysms of the ascending aorta, they are completely not related either to aneurysms in the abdominal aorta. So they are very different entities, actually, and it's very important that the population, the general population, understands that.
Right.
Now, we as medical community, we are here to treat patients, of course, but we are here also to prevent problems, to introduce prevention of the problems, and not just to be reactive to the problems.
Right.
And that's where our education needs to go, in preventing, in recognizing, as you were mentioning before, the different diseases of the aorta, the diseases that affect the proximal aorta, which is the ascending, the aortic arch, that are completely different of the diseases that affect, for example, the abdominal aorta, like the degeneration or atherosclerotic processes.
Right. Right. However, if somebody were to have one of the thoracic and they have a family medical history, not just, let's assume they're not over 65 male, heavy smoker and have high blood pressure, but if they've had a family member have a dissection or whatnot, then I would think that you'd want to monitor at least every couple of years, take a look all the way down into the abdomen just to make sure there isn't something growing, regardless if they have all those other components that would additionally put them at risk. Just take a little peek-see, right? And just make sure.
Yes, absolutely. Yeah, absolutely. Otherwise, the other way, sometimes you detect aneurysms in the abdominal aorta, and then you do have a peak to the proximal, to the thoracic aorta, and so on. And you say, well, is this an aneurysm just in the descending aorta, or has it been an extension and a progression from something else?
True. Right.
At the end of the day, the aorta is just one tube that is fully connected, and problems in the ascending aorta, on the aortic arch, they can extend. What I was trying to say earlier is that there are particular disease processes that affect one segment of the aorta or the other one. but that doesn't mean that the expansion, that the dilatation of the aorta cannot progress into the other segments of the aorta.
Exactly. Which is what we've always found fascinating. And I guess positive and negative, there are some organizations that strictly focus on valve disease and the subsequent aneurysm right there. Then there's some that strictly focus on thoracic aortic disease. And that's great because then there are places for people that only have that to go if they want support and information. But what I don't hear sometimes is a lot of information about, well, here's something to keep your mind aware of. This could also happen, so just be aware. And conversely, I don't know that I hear in the abdominal area, hey, you might want to also recognize this could happen in the thoracic area. So, we cover top to bottom, and I just still find this very fascinating that they're not being covered or at least mentioned, which is why I like to have the physicians mention it here, and hopefully more people hear this and learn about it. So, and it would be potentially hereditary, I would assume. My father had an abdominal, never really grew past like 4.7. And then I ended up with a ascending dissection. Who knew? I didn't know I didn't even know to be a compliant patient and take my blood pressure meds at the same time every day. I just would willy-nilly took one. Next day, I forgot. Nobody explained to me what could actually happen. I had no idea until I found out. And now you look back and you're like, oh, and then dad had this, and then you have to wonder if somebody else in the family who just suddenly passed, was it's heart related? I don't know. You start to realize all these things. And that's why I'm glad that you're mentioning it. I think people need to hear that there isn't, like I said earlier to this other physician, there isn't like Charlie on the thoracic side of the diaphragm and Harry on the abdominal side saying, no, you can't cross. There's this imaginary line and I can't cause a disease element towards you. It just is a vessel at that point. It is one.
Exactly. Exactly. Is that, I think, yes, you're absolutely right, and you cannot just encase the different different diseases just to one segment of the aorta, because at the end of the day, it's only one vessel.
Right. Exactly.
And it is important for the medical community to recognize that this only one vessel is fully connected, and that processes can sort of wander into into the next segment and so on. Yeah, absolutely.
Okay.
Yeah.
So I was curious to know, because I do love to give physicians an opportunity to talk about some of the treatment or research or wonderful things that you might be working on out of your facility. Is there anything that's really you see innovative coming down the pike? I know a couple people, like somebody at Hopkins was talking about AI and VR, and took me on a journey through my aorta virtually, which was really cool. That's how I found out I had dissected a little into a carotid, which took 9 years. Didn't know that before that technology came out. We just assumed that wasn't the case. And then when we saw it, my cardiologist and I live were like, wait a minute, we never ever said those words before. We'll talk offline. And I was really surprised but not surprised to realize that when you can go into the aorta, you might find out more things that you didn't realize when you're looking from the outside. Pretty interesting stuff. So tell me what's going on with you guys.
Absolutely. I think, I said, I arrived here 4 months ago, so I'm still finding my bearings and then finding my place and what to do from that point of view. But if I see what my practice was in the United Kingdom, for example, before traveling here, if you named yourself as an aortic surgeon, is in some way you can treat the whole of the whole of the different segments of the aorta.
Right.
And when you go and treat one segment of the aorta, you need to be prepared that when you open the aorta, you may find something different extending into the other segments of the aorta, and then you need to be able to treat those segments of the aorta. I think probably one of the most interesting innovation that has recently been recently here in the US, because it's about 2 years old probably in the United States. I guess in Europe we've been treating with these special devices, for example, for the past, at least for the past 12 years, I will say, which is the introduction of what is called the frozen elephant trunk. Yeah. So it is a very innovative way of treating the thoracic aorta, the aortic arch, and the ascending aorta in just one go. Whether in the
one piece, right? It's like a graft that goes into a stent. It's a one unit.
It's just one unit, exactly.
Yeah.
So
Amazing.
It's a long unit where you operate on the patient, you open the aorta, and then you deploy this stent, a sleeve that opens in the descending aorta, and therefore allows immediately treatment of that descending aorta.
Yeah.
And then to this sleeve stent, there is a graft that is attached with which you're going to replace the aortic arch. And the other end of the graft will replace the ascending aorta. So in the past, you couldn't do everything in one go. In the past, you had to do different operations to treat the different parts. Nowadays, you can do it with just one procedure. You replace all of that.
So I'm wondering, statistically, are they finding that maybe that's, let's say if a patient has a type A that goes into type B, regardless how far, instead of medically managing them, are they finding statistically that this is the best way versus just replacing the ascending, that they might as well just do this for everyone because they're basically creating an insurance plan that they're not going to need to go back in to fix any of those areas, or when would that be used then? Is there a special case?
I think you need to be very careful with the evidence that is to support this type of treatments. There seem to be some evidence that is being built up that might be the case, that probably patients with type A dissection, that type A dissection, just for the population, for the general community, is an aortic dissection that involves only the ascending aorta. But this type A dissection can also extend into the aortic arch and into the descending aorta. Yeah.
Yes.
You and I know that, but there may be people that are listening here that they not necessarily know that. So with this device, yes, you can treat absolutely everything. When the ascending aorta, again, for the general public, when the ascending aorta only is treated and there is remaining dissection, we know that at least half of those patients will come back for redo operations to sort the aortic arch and the descending aorta. And by using these devices, these frozen elephant trunks, that's what we want to see. You are preventing patients from needing secondary operations, further operations. So that's what we're trying to do. Whether that is the best operation or not, we still need to see. Evidence needs to be gathered, and we need to see whether that is the case or not. And one of the problems is that this type of operations you can only do in high volume centers and centers of excellence, where there is the human capacity, the surgeons, and the technology to be able to do this type of operations, because it's quite a complex operation. So it needs lots of expertise. So it's not an operation that should be done anywhere in any cardiac center.
Right.
Because if you're going to do only one or two a year, it's very likely that the outcomes are not going to be as good as it would be in a center that is doing 20 a year, for example, or 30 in the year.
Right. Statistically, that makes sense. That makes sense.
Yeah.
Okay.
Yeah.
Okay.
Yeah, exactly.
Yeah. Before I ask my next question, so many of my questions, I tell this to everybody, have to do with myself. I admit it. And then many questions come from the community because I just read the pages and study before we speak. I want to talk with Joshua and find out who's with us to say hi. Make sure not everybody's eating dinner, and see if there's any questions.
Well, we don't have any questions yet, but we do have a good group of people. Belda, Brenny, Tom, Jeanette, Natalie, Christina. What's up, everybody? Say hi to the doctor.
Hey everybody.
Fantastic.
Don't be afraid to ask questions. I know it just takes one of you and then all of a sudden they start coming in. So think of your questions and put them in chat, but we appreciate you being here. All right, let's talk about valve replacement. Okay, so I'm going to need to have mine was resuspended. I'm at about 40% regurgitation and like 4.7 at my Valsalva. Okay, so but I really don't want to have my chest cracked back open, but I know as of today, that's what I would need to have done. Are you hearing any rumblings? Like if I could hold off and just stay symptomatic and live with it for like another 2, 3, 5 years, is there ever going to be a chance where they could maybe replace or deploy something inside that area and I don't have to be cut back open again?
I think that's a very interesting, is a very, very interesting question. And it's a very modern question as well, because we see every day that more and more surgical procedures are being done without the classic opening of not necessarily the chest, but the abdomen or any big intervention. And progressively more and more procedures are being done under I don't want to say minimally invasive, because the minimally invasive does include opening parts of the body. But what I want to get through it is procedures that are done in the radiology lab via the arteries, just by puncturing the arteries and deploying different stents or prostheses or whatever it is inside the vessel without opening the patient. Yeah. And from that point of view, we know that nowadays the aortic valve, in certain conditions, and I would like to highlight that, in certain conditions and in certain amount of patients, can be replaced in that way. The TAVR procedure, for example, which is a trans-aortic valve replacement, is a procedure whereby the physician introduces a catheter in one of the vessels of the mainly in the groin and the femoral artery, and through that, under fluoroscopic vision, will advance a valve that is completely crimped into the through the aorta to where the aortic valve is sitting, and then it will deploy that valve at that level.
And that would be a bioprosthetic.
And that's exactly that's the issue. That is a bioprosthetic, is a bioprosthetic valve, and that's why I was saying it's not for every single patient, because the bioprosthetic valves, the younger you are, the quicker, the faster they degenerate. So they will need replacements in the future. So if you are too young, you are 40 years old or 50 years old, it's very likely that in 10, 15 years time, that valve will need replacing again. So for those patients may not be the best solution. Yeah? Now, for patients with aortic incompetence, for example, that this valve first before I go into the aortic incompetence, this valve needs the presence of calcium to support itself in the aortic at the level of the aortic annulus.
Okay.
And that calcium is present in aortic stenosis. Yeah.
Okay. So are you saying a patient who has stenosis might be a better candidate for an endovascular aortic valve repair?
Exactly.
Okay.
Exactly. Okay. Exactly. That's the message. And therefore, a patient with aortic incompetence, which is unfortunately what you see in patients with aneurysms of the ascending aorta, Marfan syndrome, or aortic dissections, for example, those patients, unfortunately, today, they are not suitable candidates for any of those. There you are, for any of those operations. Now, those patients, it's not that they cannot have an operation. They just cannot have this type of procedure. Those patients with aortic incompetence, they can still have an operation. And nowadays, we are trying to repair and to preserve the aortic valve. We replace the aortic root, and we do what is called a valve-sparing root replacement. So the patient keeps its own valve, rather than replacing it.
All right. So is there a condition in which somebody wouldn't be a candidate to have it? I guess what do you guys just tighten it up? Is that what it's doing? That's what I envision in valve sparing. I'm like, oh, you're just kind of tightening up that looseness that's going on there.
But no. What you do in the past, a patient with Marfan syndrome, for example, and a dilated aortic root would go to the surgeon, have an operation, and he would do a full aortic root replacement. Would take the valve out, would take the aortic root out, and in place would put a new valve with a neo aorta.
Okay.
Yeah. In the valve sparing root replacement, you take the root out, but you leave the valve, and you reimplant the valve inside the tube, inside the graft.
Okay.
Now, by doing that, you giving, or the graft that you're using is a graft that is the size that the aorta should be.
Okay.
So by doing that, it's not that you're shrinking the valve, you are resitting the valve in a normal size aorta that is not the normal tissue. It's a graft, but it's the normal size that the aorta should be. And by doing that, you repair the aortic valve.
Okay.
And you sort the aortic incompetence, for example.
Which I would think anybody would, if given the opportunity, you'd want to have your own natural tissue anyway.
I would like to have that, for example.
Yeah. Because then it sounds like you don't have to worry about time frames with a bioprosthetic or blood thinners with a mechanical and potential sound that you don't want to listen to. You're just back to having your own valve. Now, if you had your valve spared the first go round when you had a dissection repaired, can they try to do that same procedure again?
Say again.
If you've already had a valve sparing procedure when you had your first dissection, because I know a couple people who have had that, and now your valve has become, it's regurgitating. Can you have a valve sparing procedure done again?
Yes, you can. However, first of all, it's much more difficult because it's a reoperation. So it will add a certain problem. Number two, what you need to look into is what is the mechanism that is leading to the aortic incompetence. Because if it is that the leaflets are these little membranes that open and close in the aorta, and you can spare the valve if the leaflets are when the leaflets are normal. So if the new regurgitation is because these leaflets have become infected, for example, and destroyed, or they have retracted, for example, then there is no way that you will be able to repair that valve anymore.
Okay.
Yeah.
So then you're stuck with, when you're open, because there's no choice, are you going to do mechanical or are you going to do bioprosthetic?
Yes.
And that really, part of you weighing that decision would have a lot to do with your age. It sounds like would be a primary factor. Okay.
Exactly.
How many times can you have a bioprosthetic replaced? So if I wanted to go with that, because I don't want blood thinners for the rest of my life, or the tick-tock might make me cuckoo. How many more times? Because let's say if I'm able to wait until I'm 58, how many more times after that would I have to go? Let's say I make it to 70 and now I'm going to need to have it replaced. How many times can you do it?
As I was saying, the older you are or the younger you are, the faster the valve will degenerate. So if you have your valve replaced at the age of 50, it's very likely that at the age of 65, something like that, you will need a new valve replacement. And then when you get your operation at the age of 65, it's most likely that you may not need another operation, because you are already 15 years older, and it's very likely that new valve is going to degenerate much slower than the first valve that you had.
All right. Benefit of being older. That's a good one.
That's number one. That's number one. Number two is, should you need, let's say, a third replacement, nowadays these TAVR valves, the transcutaneous valves, you can implant those valves inside the prosthesis.
Okay.
So you still have another option, which is that one.
So you could do it again one more time
without having to open your chest.
Yeah.
So I think medicine has evolved quite a lot, and there are, as I was saying, the medicine and science is looking into trying to make all of these procedures as little invasive as possible.
Right.
We're not there. We're not there yet. The future is the future. But we may be there one day for everyone, actually, young patients and older and more elderly patients as well.
Which would be great. It would be
It
great.
would be great. Yeah, absolutely. Absolutely. I wouldn't have a job. That's the only downside. Is the downside to that. But anyway.
All right, Josh, I want to check in and see if anybody else has joined or if they have questions.
Everybody, I think, is captivated by your accent, Doctor.
They just are.
I think so. I'm enjoying it. I love it.
Or maybe I'm just asking all the right questions. I don't know.
I don't know what my accent should sound like, actually.
It sounds great. It sounds great. It's you could recite the alphabet and everybody would say, that sounds so smart. It's so smart. It's the best sounding alphabet.
It's a bit of South American mixed with British accent, and now I think with Milwaukeean accent.
Oh, well, that's one heck of an accent right there. It really is.
It's working.
It really is.
Thanks.
So there was a question I was going to ask about the valves, but now I cannot even remember what it was. Okay, so we've talked about valves, we've talked about the aneurysms, and if we're going to talk a little bit about dissections, and let's talk a little bit about dissections and mental health, because that's not discussed enough. And we're also starting to realize that the people that are watchfully waiting are also experiencing a lot of challenges from a mental health perspective. And I'm just curious to know, do you have plans to maybe implement, if it doesn't exist already, some emotional or mental health support systems in your hospital? I know a lot of people say if they met somebody who had a dissection or met somebody who had an aneurysm, it would make the recovery go so much easier. And that was part of why we wrote the book, and we have the second book coming out right now, The Patient Guide, because we knew that if somebody had a chance to read Aortic Dissection, the Patient Guide, So every time they read it, they say, God, I wish this was out when I had my dissection.
Yeah.
Because they know it's written by patients. So it's a piece of normalcy to them. They can see, well, number one, a patient wrote this, so clearly they're alive and they're functioning like a normal person. But I just wonder why, if we're told when we are discharged, we have to make an appointment. And I remember this with my primary care, my cardiologist, to follow up with my surgeon. And then at some point I'd get my script for cardiac rehab. Nowhere in there did anybody say, we also want you to do a check-in with a therapist. If you don't have one, we'll give you a list. And what would be ideal would be, we're also going to set you up to meet with a patient representative, somebody who is right there with you. I feel like that would be your recipe for success. What are your thoughts about that?
I think that's very, very interesting. And I have to say that is one aspect that is very much neglected. I need to say, aortic dissection happens suddenly in someone that is completely healthy, we believe is healthy, is doing an absolutely normal life, goes to sleep, and then in the middle of the night wakes up with pain in the chest, rush to the emergency department, and then diagnosed with an aortic dissection and has a huge operation from which recovers.
Yeah.
And then I can imagine that patient actually coming out of the hospital being completely shocked that 24 hours before or 7 days before being discharged from hospital was a complete normal person, didn't think was anything wrong with him or with her, and then all of a sudden feels that actually I am labeled, I am fragile, anything can happen to me. And I escape from this one, but what can happen in the future? Will this happen again, or something similar may happen again? And you're absolutely right. I don't think in every single center that is well developed, a good support group of patients themselves that support other patients, that actually doesn't exist. And I think it is something that by Aortic Hope or raising awareness, aortic awareness, Think Aorta, and all those institutions and organizations, we should probably get together and develop groups of support, because it's very likely that the patients with aortic dissection, unfortunately, they're not going to just have one operation. They're going to need further treatments in the future as well. We need to remember that half of the patients that underwent repair of an aortic dissection, half of them will need other procedures in the future. Now, by using the frozen elephant trunk and all that sort of thing, we're trying to make that 50% that need further treatments less.
Okay.
Yet, still, there will be a number of patients that it will need more treatments.
Right.
But yes, you are absolutely right. I think introducing techniques where, for example, which I have done quite a few aortic dissections where we have preserved the aortic valve. Within all the negativity of the aortic dissection, there is something positive. You have managed to preserve the aortic valve.
Right.
And that is better for the patient. So that should be a little bit of an encouragement of the patient. Still has had the operation and everything, is nothing you can do about that. But at least that patient is not going to face problems derived from the valve, for example.
Right.
May need other things. Okay, so we need to try and teach all of these techniques to the new doctors that are coming, so that they can offer that type of treatment to their patients when they see them.
Because I don't think this was anything that was regular 10 years ago.
No,
because I know it certainly
not.
wasn't.
No,
certainly wasn't offered to me. And I feel like, yes, I hear that there's a lot that still needs to be considered from the physician's end on the physicality of surgery. And I do think that while you're stretched too thin and there's not a lot of time for you to do these other things, my dream would be one day, even via Zoom or something like this, that you say on your schedule, okay, so we've seen 3 aortic dissection patients this month. Let's all get them in on a Zoom call to meet somebody from a patient, organization, so that they know the resources that are out there.
Yes.
All they have to do, they just meet them. They know they're just like them. Let's get the caregivers. They get an opportunity, and maybe it's done every 3 months, but people have an opportunity to meet. I feel
Absolutely.
confident the road to recovery would be a lot stronger and sooner. And I also think that patients then might have a chance to be educated on the importance of follow-up. I mean, in remote locations, we know that follow-up is going to be challenging. In inner city, follow-up is always challenging. I think a lot of times people think, I had my surgery and I'm done. They don't mention it to their children. They're just not thinking it can happen to them again or to someone they love. But meeting with people just like them, then it's like they may listen more, or at least remember something.
You're absolutely right, especially in patients with connective tissue disorders, where we know that the problem is genetic, and because it's genetic, can be transmitted to siblings.
Right.
And to the descendants of the family. So it is an issue that needs to be spoken about. They need to be talked about. And I agree that it is necessary, the support of the medical community, to have that conversation and to be able to have to be confident, actually, and in that they're being looked after. Not just the patient, but also the family, and they have that security. Yeah.
Hey, that can be our initiative. Let's start something in 2026.
Yeah. Why not?
And maybe it'll take off. Who knows?
Yeah.
I think it makes sense. And I don't think it would cost. It just, you know what it costs? It costs the passion of someone. That's all it is.
The effort, exactly, is the effort of saying, okay, we're going to get people together. And let's introduce people to people and so on. And that's how things grow. Yeah.
I love that.
Absolutely.
I love that. Absolutely. All right. I'm going to do a quick check-in with Josh, because for all I know, you might have to do another transplant tonight. I don't know. You're a busy guy.
Or aortic dissection.
Or dissection.
Who knows?
You never know.
Exactly. You never know.
Josh, what's it look like?
We do have something here.
Okay.
Let's see. So the patient has requested, I am 42 years old. I have a type A residual type B dissection with a porcine valve. I had extreme aortic insufficiency. I was also just diagnosed with thyroid cancer issues, and I need a thyroidectomy. Okay, he's nervous about surgery, worried about arch replacement in the future. The dissection is carotid to the bifurcation. He's got a lot of questions, but he's waiting on genetic test results. Is a thyroidectomy a huge deal because of the dissection?
I will say I don't do thyroidectomies, but the thyroidectomy is an operation that is done at the level of the neck, so it doesn't need to wander into the into the chest, unless I have to say that sometimes some of the goiters and enlargements of the thyroid gland, they sort of drop inside the chest. However, having said that, the thyroidectomy is not a problem to be undertaken with in a patient that has had an aortic dissection. Yes, I fully understand the worries of the patient. He's a young patient. I understand his worries that is very likely that will need further surgery. Nowadays, aortic surgeons like myself, for example, we know that we're going to be doing lots of reoperations. Aortic surgeons is a little bit like pediatric congenital surgeons that face lots of reoperations. And the important thing is that someone with the necessary skill, with the appropriate skills, will do that intervention. Is that the intervention will be done in a center where aortic surgery is done day in and day out, every day.
Mm-hmm.
But you can have your thyroidectomy if it is necessary to do.
Thank you,
Josh?
Doctor.
Thanks.
Okay.
Anything else?
Bernie likes the idea of going from hospital to hospital and meeting new patients. We need to get him a cape or something.
Right, I see.
Arrive as an aorta. I'll just come into the hospital.
Exactly.
It's aorta day.
Yeah.
Any other questions or thoughts?
Christina was kind enough to share that she had her thromboidectomy a little bit before she had her dissection, and she was letting Jason know that that recovery was pretty easy. So I mean, but it's the complications, it's always the complications will come into play.
I think it's also, you have to look at it from a cost benefit. I've had an ostomy surgery. I've had my gallbladder taken out. I've had a shoulder manipulation from a frozen shoulder. And, if I wouldn't have had that, each of those, the pain and potential for inflammation markers going sky high, and my heart working harder to rid this inflammation, and blood pressure and stress and anxiety, it just made sense. I didn't want to have gallbladder stuck in a bile duct. That's not what you want. So I needed to have that done before there was a chance I needed to have any other additional aortic surgery.
Yeah.
And I'm just going to say, abdominal surgery, so much worse than heart surgery, so much worse than a sternotomy, because you can use your stomach muscles when your chest is cracked open. But when you move your stomach muscles, you're like, you can't do anything. You can't even, it's so hard. It's so painful. It's so yucky. Yeah. But you do what you gotta do.
I agree. I agree with you. Yeah. It's terrible.
Ooh, those stomach muscles are a beast. Yeah. Well, listen, Dr. Mascaro, this has been so wonderful. I feel like we could just sit and we could just talk and talk and talk. And I want to have you on again. I want to be very topic based. I'm going to pay attention to a few things. I know that in the fall, we definitely have some conversations about the flu or COVID, vaccines and different things. And so I think it would be interesting to talk a little bit about what these things do to our body, and just why it's necessary to have the conversation to discuss if you're a candidate for a vaccine, and if not, for whatever your reason is, what are some medications we can and can't take? What do they do to our bodies? Why are we told no Sudafed? Why are we told no Advil? So, why are we left to be miserable with just a box of tissues? What can we do to make life a little bit easier in the colder winter season that's coming up? So I would love to have you on again if we could after, in January.
I'd be delighted to help. Absolutely.
Wonderful. Well, thank you so much.
Yeah,
I'm so thankful that you took time out of your evening after given the evening you told me you had yesterday. I would have been like, I have got to sleep, but you are Superman in and of itself. So thank you again. I really appreciate it.
No, thank you very much. And I hope that it's been clear, and for the patients that are listening at the moment, it has been helpful to them.
Oh, I guarantee you it has been. And to all of you, thank you for joining us tonight. Please don't forget to click like, share, and subscribe, because we've got some other live events and things happening this month. And please share this on your page, because I guarantee you someone else will find something very educational and informative from this event. So from all of us, thank you again so much, and we'll see you soon. Have a good night.